All right. I think we're going to get started just to make sure that our presenters have enough time. Welcome, everyone. Thank you for joining us. My name is Talia Farouk. I am a neuro-ICU clinical pharmacist specialist at the Johns Hopkins Hospital. Other moderators with me today are Dr. Leslie Hamilton and Dr. Corinne Berger. And we're very excited to have Dr. Catherine Harville from Novant Health and Dr. Deanna Shim from University Health. And with that introduction, Dr. Harville, would you be able to share your screen, please? We're excited to hear your presentation.
Yes, I'll go ahead and pull that up. Can everybody see that clearly?
Yes.
Okay, perfect. So good morning. My name is Catherine Harville, and I'm a PGY2 acute care pharmacy resident at Novant Health Fresno Medical Center, presenting on Argatroban in patients with acute ischemic stroke with early neurologic deterioration, a randomized clinical trial. So ischemic strokes are characterized by a blocked artery that interrupts blood flow to the brain, resulting in an acute loss of function. Early neurologic deterioration, or END, is, as I'll refer to it for the remainder of this presentation, it's determined by the clinical worsening or recurrence in the first 48 to 72 hours after acute ischemic stroke onset. It has a pretty high prevalence, resulting in 10 to 40% of all ischemic strokes, and is associated with worse functional outcomes at 3 months. There are multiple etiologies that can come into play with the progression of END, some that are better understood mechanistically than others, including hemorrhagic transformation, post-fibrinolytic use, as well as cerebral edema. I just want to point out a couple of etiologies that have some less understood mechanisms to target therapeutically. There's a prospective study in 2015 that found that poor baseline collaterals were associated with longer clots, specifically potentially identifying a mechanism to target critical stenosis and large vessel occlusion with collateral circulation failure. Another study in 2017 found that unexplained END was independently associated with vessel sign extension post-thrombolytic therapy, again suggesting that unexplained END may be associated with thrombus extension. Looking at Argatroban, this is a direct thrombin inhibitor with immediate onset of action and short half-life, readily available for titration. The thought is that blood stasis near original thrombus allows it to propagate and worsen neurological function over time. Argatroban is a direct thrombin inhibitor that has multiple pathways of inhibition, including platelet activation, thrombin formation, and platelet plug formation via von Willebrand factor. So by targeting all of these mechanisms, it can hopefully prevent thrombus extension and improve neurologic symptoms. The 2019 guidelines for early management of acute ischemic stroke do not have a statement on the usefulness of Argatroban and other direct thrombin inhibitors for the treatment of patients with acute ischemic stroke. However, there's a Class A recommendation to not use urgent anticoagulation with the goal of preventing early recurrent stroke or halting neurological worsening, which is the patient population that we're discussing today. Now, why is that the level A recommendation? These are a few of the landmark randomized controlled trials that were published in the most recent decades, looking at the use of conventional anticoagulation in acute ischemic stroke. There's the International Stroke Trial, TOAST, and TASTE trials that all include patients with an onset within 24 to 48 hours of stroke. They included the use of unfractionated heparin, a heparinoid, and low molecular weight heparin. Specifically looking at our international stroke trial, there were significantly fewer recurrent ischemic strokes within 14 days, but this was offset by a nearly equal risk of intracranial hemorrhage. Looking at our TOAST and TASTE trials, there was no difference in favorable neurologic outcomes or modified Rankin score at 3 and 6 months, but also displayed a significantly higher risk of bleed in both studies. So ultimately, looking at the early use of conventional anticoagulation, there was no difference found in functional outcomes with an excessive intracranial bleed risk. However, this has led to the use of more unconventional anticoagulation in the most recent years, specifically the use of Argatroban. So here I've included some of the most recent randomized controlled trials, including Argus-1, Argus-2, and the Arias trial. They all include varying NIH stroke scale scores at presentation, but ultimately use Argatroban, either low or high dose or in combination with alteplase therapy within 4.5 to 12 hours of acute ischemic stroke onset. The Argus-1 trial was a safety study that found significantly increased APTTs, or activated partial thromboplastin times, with no difference in asymptomatic intracranial hemorrhage. The Argus-2 trial was an exploratory study that found an increased probability of superiority to TPO alone, with combination with Argatroban therapy and no increased risk of intracranial hemorrhage. And finally, the Arias trial did find no improvement in excellent functional outcomes at 90 days, but also no difference in the incidence of end. Again, safety, no increased risk of bleeding, hematoma, infarction, or major systemic bleeding. So ultimately, the early use of Argatroban did not find a difference in functional outcomes, but also had no increased risk of intracranial hemorrhage or severe systemic bleeding, indicating a safety measure. So finally, there were studies coming out within the past few years looking at Argatroban therapy specifically in early neurologic deterioration with acute ischemic stroke. So these are 3 retrospective cohort studies, specifically including stroke etiologies with a high risk for end, to see if these patient populations can be better targeted with Argatroban therapy and reduce the progression of end. The interventions include Argatroban continuous infusion plus DAPT or dual antiplatelet therapy versus DAPT alone. And all 3 studies included the dosing on the screen, 60 milligrams per day for 2 days, then 20 to 30 milligrams per day for 2 to 7 days. The first study did dose adjust the Argatroban infusion based on a goal APTT of 1.75 times baseline. The second study only looked at APTT at 24 hours and found that the Argatroban group did have twice the length of time as the DAPT group alone. Looking at outcomes, our largest study did not find a significant difference in the development of end, but did find a difference in NIH stroke scale score with Argatroban. The last 2 studies did find a significant reduction in end, as well as improvement in modified Rankin score and a reduction in poor functional outcomes at 90 days. All studies did display safety, with no cases of intracranial hemorrhage found in any study. But again, these studies are focusing on endpoints looking at the incidence of end and improvement in functional outcomes. So specifically to discuss gaps in literature, there's not currently a large randomized controlled trial with generalizable stroke etiologies looking at Argatroban use, specifically targeting the end population. And the effect of Argatroban in reducing the progression of diagnosed end is another major gap in literature, since all of these studies are looking at if end develops rather than if it can improve outcomes in patients that already experience end. So this brings us back to our study of Argatroban in patients with acute ischemic stroke with early neurologic deterioration. This was published in JAMA Neurology in February of 2024, so this month. The purpose was to assess the efficacy of Argatroban for early neurologic deterioration and acute ischemic stroke. It was funded from grants from the National Natural Science Foundation in China, and no conflicts of interest were reported. This is a prospective, randomized, open-label, blinded endpoint trial, including 28 medical sites in China. Patients were included if they had an NIH stroke scale score of more than 2 or more increase within 48 hours of acute ischemic stroke onset. There's a dynamic stratification system to ensure well-balanced subgroups, including age, sex, and NIH stroke scale score randomization to either receive Argatroban continuous infusion of 60 milligrams per day for 2 days, followed by 20 milligrams per day for 5 days, plus standard therapy versus standard therapy alone. And patients were continued to be treated with standard therapy up to 90 days, which is when they measure the primary impact. They also required at least 24 hours from IV thrombolytic therapy with no evidence of hemorrhage on CT before enrolling patients. I'm not going to read out all the exclusion criteria, but I did want to point out that they excluded patients with cardiogenic cerebral embolism, a pre-stroke modified Rankin score greater than 1, or a severe heart, liver, or kidney dysfunction as described below. Argatroban was terminated immediately in all patients with major systemic bleeding and symptomatic intracerebral hemorrhage suspected. The primary endpoint was defined as the modified Rankin score of 0 to 3 at 90 days. The secondary endpoint included the modified Rankin score of 0 to 2, as well as categorical shift at 90 days, as well as the Barthel scale score. NIH stroke scale scores looked at 7 and 90 days, and there was a composite cardiovascular event at 90 days endpoint, including the following. Safety was determined based on intracerebral hemorrhage, which is defined as bleeding on a head CT with clinically significant neurologic deterioration, as well as a peripheral hematoma type 2. For statistical analysis, they did complete a per protocol and intention to treat, with patients required to have at least one protocol treatment and efficacy evaluation. They did calculate a sample size of 630 patients based on an 80% power to detect the primary endpoint of a modified Rankin score of 0 to 3 at 90 days, and no interim analysis were conducted. They utilized generalized linear models for the statistical analysis, with the primary endpoint utilizing ordinal logistic regression and odds ratio, and secondary endpoints with risk ratios and risk differences to 95% confidence interval for each. There was also a pre-specified subgroup analysis based on age, sex, NIH stroke scale score, time from symptom onset to randomization, and reperfusion therapy. Patients were enrolled from April 2020 to July of 2022, with 628 patients eligible for enrollment. There ended up being 314 patients randomized to each group, with a similar amount lost to follow-up. However, more patients did withdraw consent in the Argatroban group. I do want to point out that 31 patients in the control group, which was about 10%, did end up receiving Argatroban treatment beyond the 48-hour mark of symptom onset. So our per protocol analysis included 98% of patients in the Argatroban group that underwent the complete protocol, and about 90% treated per protocol in the control group. Looking at our baseline characteristics, there was a mean age of 66, primarily male sex, with a BMI of about 24, with a tight interquartile range of 21 to 26. For comorbidities, I did want to point out hypertension and diabetes, since they are independent risk factors for early neurologic deterioration. There's a slightly higher incidence of hypertension in the Argatroban group, but similar of diabetes in both groups. Also to point out the estimated premorbid function, most patients, 95% in each group, did have a modified Rankin score of 0 at baseline. They also had similar NIH stroke scale scores at randomization and before deterioration. I also want to point out that for both groups, the time from symptom onset to randomization was about 24 hours. So that was a pretty significant delay. Looking at antiplatelet therapy throughout the procedure, more patients in the Argatroban group did have monotherapy compared to dual antiplatelet therapy in the control group. About 13% more patients in the control group had dual antiplatelet therapy. For reperfusion therapy, about 18% of patients did receive IV thrombolysis, and a very small percentage received endovascular therapy. Regarding the stroke etiologies included in this study, it was primarily large artery atherosclerosis and small vessel occlusion compared to other etiologies, and this was the case for both groups. Looking at our primary endpoint of the modified Rankin score of 0 to 3 at 90 days, there was a significant difference found in both the unadjusted and adjusted analysis at 80.5 versus 73.3% favoring the Argatroban group. And this was a number needed to treat of 14. And this is just the distribution looking at both groups, showing how the control group has a higher number of patients, meeting that 4 to 6 modified Rankin score at 90 days. Looking at our primary outcome by subgroups, the only significant difference found was in sex with females. showing a better efficacy compared to males, but there was no difference found in age, NIH stroke scale score randomization, or time from symptom onset to randomization regarding the primary endpoint. Moving forward, there was also no difference in whether or not reperfusion therapy was used, if monotherapy versus dual antiplatelet therapy were used, or based on the patient's TOS criteria and meeting that modified Rankin score of 0 to 3 at 90 days. Looking at secondary outcomes, there was no significant difference found in modified Rankin score of 0 to 2 at 90 days, or the Barthel scale score at 90 days. However, there was a significant difference in the modified Rankin score distribution at 90 days, with an odds ratio of 0.71 in the adjusted analysis. Further looking at secondary outcomes, the NIH stroke scale score at 90 days was similar in both groups with no significant difference found, and also no difference found in stroke or other vascular events within 90 days. I just wanted to point out the per protocol analysis and how all the results are very similar between both groups, despite there being differences in baseline characteristics and the crossover that occurred. So the modified Rankin score of 0 to 3 at 90 days, our primary endpoint, as well as the score distribution at 90 days, was both statistically significant in the per protocol analysis. Looking at safety outcomes, they're very similar between groups again at symptomatic intracranial hemorrhage, cranial hematoma, and other bleeding events. Looking at the author's conclusions, there was a significant increase in good functional outcome at 90 days in the Argatroban group, with similar results in the per protocol analysis and primary and secondary endpoints. There was a potentially stronger effect of Argatroban among female patients, but no significant interaction between different antiplatelet therapies with Argatroban. There was also no difference in adverse bleeding events, including intracranial hemorrhage. So ultimately, the authors concluded that the combination of Argatroban and antiplatelet therapy resulted in a significantly greater likelihood of good functional outcome at 90 days in patients with early neurologic deterioration after acute ischemic stroke. And this study is evidence to support the use of Argatroban in this patient population. Now to discuss the strengths and limitations. This was a large randomized trial assessing the effect of Argatroban in ending progression, which is novel compared to the other studies using Argatroban. They utilized blinded endpoint assessments, even though the actual treatment was not blinded. And they utilized patient-oriented outcomes, although I did want to point out that they defined modified Rankin score of 0 to 3 as a good functional outcome, whereas most stroke studies use a modified Rankin score of 0 to 2 as that definition. The per protocol analysis yielded similar results to the full analysis set, and they included patients that received IV thrombolytic therapy and or thrombectomy. Some of the limitations include an open label design without placebo utilization, which seemed like a missed opportunity, especially considering that they didn't do therapeutic drug monitoring while on the Argatroban continuous infusion. And with this open label design, there was a higher utilization of DAF into control group by about 13%, as well as high crossover rates in the control group, about 10% of the control group receiving Argatroban therapy. The study was ultimately not adequately powered, and there was questionable generalizability with the Chinese population, and just wanting to point out that they do have a higher risk of having CYP2C19 poor function metabolism regarding their ability to have better efficacy with clopidogrel. There's also a variation in BMI that's low among patients included with a tight interquartile range and a lack of information regarding APTT monitoring throughout the study. They also initiated Argatroban 24 hours after thrombolytic therapy, which based on previous trials that have been completed that I talked about earlier, the ARCS-2 and ARIAS trials, those did demonstrate safety of Argatroban use even earlier after 4.5 hours of thrombolytic therapy. So looking at clinical applicability, there's a possible benefit with the early initiation of Argatroban to improve functional outcomes in early neurologic deterioration with acute ischemic stroke. And this is generalizable to our large artery atherosclerosis and small vessel occlusion patients, concomitant antiplatelet therapy, and post-IV thrombolytic therapy. This also addresses a treatment gap for patients with early neurologic deterioration and able to receive thrombectomy. There is a positive safety outcome regarding bleed risk found in the study, but with the questionable crossover and the fact that they used the full analysis set in our safety outcomes, there is questionable reliability of those. There was also a lack of protocolized monitoring of APPT, which limits replication of the study moving forward, as well as a questionable dosing strategy given the size variation among patients in the United States. The dosing was pretty low, about 20% of usual dosing of Argatroban that we see in normal therapy. And given that United States patients tend to have a wider variation of BMI compared to the Chinese population and what's seen in this study, the average milligram per kilogram dosing is questionable regarding efficacy and if we would see the same outcomes. So moving on to just current literature that came out to kind of add to this study in how to manage patients. The multi-arm optimization of stroke thrombolysis or MOST trial was just recently presented at the International Stroke Conference. It was a randomized, double-blind, parallel assignment phase 3 trial that looked at improved 90-day modified Rankin scores post-acute ischemic stroke. They actually had 3 arms to this trial, looking at Argatroban, eptifibatide, which is a GP2B3A receptor inhibitor, versus placebo, and this was all with IV TPA or TNK therapy within 3 hours of stroke onset. Ultimately, the study was ended early because they found no difference in the 90-day modified Rankin score, but also no significant increased risk of intracranial hemorrhage. Looking at a couple of other recent studies that came out, Tirofiban for stroke without large or medium-sized vessel occlusion, or the Rescue BT2 trial, was presented at this past Journal Club in November and did include patients with an NIH stroke scale score of 2 or more increase within 24 to 96 hours and the progression or deterioration after thrombolysis. So it included this end population, as the study that we talked about today did, and found a difference in modified Rankin score of 0 to 1 at 90 days, with only 1 case of intracerebral hemorrhage in the Tirofiban group. There's also a study that was just also presented at the International Stroke Conference, the TREND trial, that included patients with focal cerebral ischemia and NIH stroke scale score of 4 to 20 with no thrombolysis or endovascular thrombectomy treatment. Ultimately, they did find a difference in NIH stroke scale score increase of 4 points, but no difference in functional outcome modified Rankin score of 0 to 1 at 90 days, and no difference in systemic bleeding. So again, based on these 3 trials that recently came out, there tends to be a better response to patients starting therapy with either a Argatroban inhibitor or GP2B3A inhibitor for patients that have end in progression as compared to starting it empirically, for lack of a better word, to prevent the progression event. Thank you all for listening. Do you have any questions?
Great presentation, Dr. Harbaugh. That was very, very comprehensive. So great work. I'm going to look at the chat to see. I think I saw one question about, can you tell us about the DAPA regimen that they received? Did they comment on the actual medications that they used? Was it aspirin and clopidogrel, or was it aspirin and ticagrelor, or any other combination that might have been mentioned in the study?
It was specifically aspirin and clopidogrel,
Okay.
which is why I wanted to point out with the Chinese population and having a higher incidence of being Plavix non-responders. I thought it was interesting that that was the specific regimen in the study. Great.
I actually have 2 questions. I don't see any other questions in the chat. Very good job talking about how they define their primary outcomes, and I agree with you that MRS of 0 to 3 seemed a little bit generous for good functional outcomes. Typically, that's not something that we consider in the US for good outcomes, functional outcomes. Can you comment on, number 1, as far as the NIH scale that they looked at for their patients for baseline characteristics, the range, and what you think about that? Do you think they included really sick patients, or do you think that they could have, kind of be more inclusive of other patients with maybe higher degrees of severity of stroke? That's my question number one. My question number two for you is that, do you think there's something unique about Argatroban that we're seeing Argatroban come in and going from time to time, or do you think that this whole general idea could be applied to other direct thrombin inhibitors, such as, bivalirudin and other agents? Can you comment on those two questions, please?
Yes. So the patient population, based on their NIH stroke scale scores, they all were in more so the mild stroke category. And I do think that's interesting because patients that do worse more quickly or more likely to develop early neurologic deterioration. So I think this is a potential missed opportunity. I think that is one for this study. And regarding the use of Argatroban, I mean, again, it does hit those multiple pathways of inhibition with clot formation. So it's thought to be more efficacious compared to other agents. I did actually look to see other direct thrombin inhibitor use, and as far as like the bivalirudin, I found one case report back in 2004 for its use. So I couldn't really speak much to that as to why we use Argatroban versus other agents. But I do know that, it's commonly used at our facility and is our major alternative to heparin. So there's more familiarity with it, as well as how to do APTT monitoring and goals and titration of that agent. So I know just specifically for us, there's some familiarity where I could potentially be comfortable with its use. However, I think in this study with the dosing used and the lack of APTT monitoring, I'm not super confident in the utility of recommending this specific regimen for patients with early neurologic deterioration.
All right, excellent, great. Are there any other questions for Dr. Harville before we move on to the next presentation? All right, great work. Dr. Shim, you're up.
All right, can everyone see my full screen?
Yes.
Okay, perfect. Hi, everyone. My name is Deanna Shim. I am currently a PGY2 critical care president at University Health, located in San Antonio, Texas. Today, I will be presenting the SECRET trial, the study of rivaroxaban for cerebral venous thrombosis. So cerebral venous thrombosis, or CVT, is a thrombosis of the veins of the brain, which can include the dural venous sinuses and or cerebral veins. CVT is a rare cause of stroke with an incidence of approximately 1 to 2 cases per 100,000 individuals every year. Another unique thing about CVT is that it often occurs in patients who are young and thus lack traditional risk factors of ischemic stroke. The biggest risk factor of CVT development is being a female, either on oral contraceptives or being pregnant. The female to male ratio is 3:1, and the mean age at CVT presentation is mid-30s. And only 8% of patients aged 65 and over develop CVT. There have been studies that have found that oral contraceptive and hormonal therapies, primarily those that contain estrogen-based formulations, may increase the odds of CVT nearly 8-fold, with possible additional synergistic effects with obesity. Other CVT risk factors include inherited thrombophilia, which includes protein C and protein S deficiencies, antithrombin deficiency, and factor V Leiden mutation. And lastly, inflammatory conditions, could also increase the risk of developing CVT, such as vasculitis or connective tissue disorders, and so forth. The clinical presentations of CVT are non-specific. Headache is the most common presenting symptom of CVT, and CVT presents with other signs and symptoms of elevated intracranial pressure, leading to nausea, vomiting, sometimes visual and focal neurological deficits. So in general, once CVT is diagnosed, anticoagulant is initiated as soon as possible. And the goals of anticoagulation in CVT are to first reduce the risk of recurrent venous thrombosis, reduce the risk of CVT extension, and lastly, to achieve cerebral venous recanalization. So the standard initial therapy is parenteral anticoagulant like low molecular weight heparin or Lovenox or unfractionated heparin as soon as possible after the diagnosis of CVT. And if patient is seemed stable and remains stable, then the transition is made anticoagulation. Not until last month, based on previous guidelines and published standard of practice, the long-term anticoagulant of choice has always been vitamin K antagonist or warfarin. However, the new hot off the press, the 2024 American Heart Association guideline now recommends the use of DOAC or direct oral anticoagulants along with vitamin K antagonist for long-term anticoagulant with CVT. So now let's take a look at some of the literatures that have helped us into shaping the new recommendation. Prior to the trial, which I will go over in the next few slides, only 2 main studies have evaluated the use of DOAC in CVT. The first randomized control trial was by Farrell and colleagues, or the RESPECT CVT trial in 2019. This trial compared dabigatran 150 milligrams twice daily against dose-adjusted warfarin with INR goal of 2 to 3, which were started 2 weeks after CVT diagnosis and was continued until 6 months. Most patients had excellent outcome with no CVT recurrence in either groups and had similar bleeding risk. They concluded that dabigatran was a reasonable alternative to warfarin for long-term CVT anticoagulation therapy. The next trial was by Yagi in 2022, or the ACTION CVT trial, which was a multi-centered retrospective study. They looked at about 700 hospitalized patients diagnosed CVT with a median duration of 6 months. Among patients who used DOACs, more than majority of these patients, so 67% of patients were on apixaban, 18% were on rivaroxaban, and the rest were on dabigatran. Again, there were similar recurrence in venous thromboembolism, which included DVTs and PEs, similar recanalization rates, and they also found that there were lower major hemorrhage risk with the use of DOACs. And although this trial was not a randomized control trial, this was a fairly well-conducted study with very large patient population size. Despite the DOACs demonstrating safety and efficacy in other types of venous thromboembolism, there still is that hesitance in their adoption for CVT due to that lack of specific evidence and concerns regarding intracranial hemorrhage. Currently, there is still that gap in literature as there is no evidence in early initiation of DOAC and also no randomized control trial looking specifically at other DOAC agents like rivaroxaban, and there has been no studies that evaluated the long-term outcomes past 6 months. So excuse me. This leads to the secret trial by Fields and colleagues from 2023. The full title of the study is The Study of Rivaroxaban for Cerebral Venous Thrombosis, a randomized controlled feasibility trial comparing anticoagulation with rivaroxaban to standard of care in symptomatic cerebral venous thrombosis. The secret trial was designed as a pilot trial to first investigate the feasibility of recruitment in patients with CVT, as CVT is a rare. Other objective of the secret trial was to address the existing uncertainties surrounding CVT management by comparing the safety of rivaroxaban to the standard treatment of warfarin or low molecular weight heparin. And lastly, the trial also aimed to identify alternative and meaningful patient-centered functional outcomes. So this trial was a phase 2 prospective parallel trial, which encompassed 12 comprehensive stroke centers across Canada. Patients were randomized in 1-to-1 ratio to either receiving rivaroxaban dosed at 20 milligrams daily or 15 milligrams in individuals with an estimated creatinine clearance less than 50 milliliter per minute against a standard of care, which included dose-adjusted warfarin with INR goal of 2 to 3 or ongoing therapeutic low molecular weight heparin. For patients randomized to the control arm, site investigators provided with guidelines on warfarin therapy, including evidence-based nomograms for INR adjustments and frequency of INR monitoring. And patients who were initiated on warfarin received bridging parenteral anticoagulation for 2 consecutive days after the INR was at the target goal of 2 to 3. The treatment was given for a minimum of 180 days or 6 months with an optional extension up to a year or 365 days at the discretion of the treating physician. And the treating clinicians were aware of the treatment allocation, but the study evaluations were performed by assessor unaware of the treatment allocation. So participants were eligible for inclusion if they were 18 or older, within 14 days of an imaging confirmed diagnosis of CVT, and were suitable for oral anticoagulation in the judgment of the treating physician. Major exclusion criteria included known antiphospholipid syndrome, anticipated invasive procedures like thrombectomy, hemicraniectomy, being unable to swallow due to altered mental status, estimated creatinine clearance less than 30, those who are pregnant or breastfeeding, and lastly, concomitant use of strong CYP3A4 inhibitors. The primary feasibility endpoint was defined as the rate of recruitment, which is the number of participants providing informed consent and the number of participants randomized annually. The primary safety outcome was a composite of all-cause mortality, symptomatic intracranial hemorrhage or ICH, and major extracranial hemorrhage within 180 days of randomization. Symptomatic ICH was defined as a new symptomatic intracranial hemorrhage or worsening existing intracranial hemorrhage with greater than 33% of change in hematoma volume. Secondary safety endpoints were the individual components of the primary safety endpoint, both at day 180 and day 165. Other safety endpoints included clinically relevant non-major bleeding, recurrent VTEs, venous recanalization, and functional outcomes. So for this study, a sample of 50 patients was chosen in keeping with realistic national recruitment targets for a rare disease. It was estimated that for a superiority trial powered for the primary safety outcome, 864 patients would provide 80% power to detect a 50% relative risk reduction in favor of rivaroxaban with 10% event rate. A modified intention to treat population included those participants consented and were confirmed to meet criteria for enrollment and agreed to continue in the study following randomization. So the study site screened a total of 219 individuals between March of 2019 and October of 2021. 164 participants were excluded, 92 patients were not eligible, 42 participants declined to be enrolled into the study, and 30 were not approached. So 53 patients were included in the modified intention to treat analysis, with 26 participants in the rivaroxaban group and 27 participants in the standard of care group. 96% completed the 180-day follow-up, and about 91% completed the 1-year follow-up. The median time on treatment for both of these groups were about a year, with the rivaroxaban group at 352 days and 333 days in the standard of care group. Now, going into baseline characteristics, were mostly similar between the groups. More than 60% of participants were females in their late 40s, which are consistent with the other studies on CVT diagnosis. Their median NIH score for the National Institute of Health Stroke Scale was 0, meaning that they had no stroke symptoms. Identified risk factors include the use of oral contraceptives, history of prior VTEs, had recent surgery, and lastly had family history of VTEs. Many of them presented with headache, nausea and vomiting, followed by seizures, and some had visual impairments. More than half of the patients in the rivaroxaban group had ICH present at randomization, compared to 30% in the standard of care group. All but one participant in each group received lead-in parenteral anticoagulation, and no patients in the rivaroxaban group required that renally adjusted dose of 15 milligrams daily. 2 participants in the standard of care group were treated with low molecular weight heparin up to 6 months or day 180, and the rest were transitioned eventually to warfarin. And INR data were available with 71% possible follow-up, and out of those, about 84% of those readings were within the therapeutic of INR 2 to 3. Now, going over outcomes for feasibility, research operations and recruitment were nationally following the COVID-19 pandemic during March of 2020. But overall, the recruitment rate was 1.78 participants per month, which translated into a total of 21 patients per year between 2019 and 2021. Now, for safety outcomes, again, the primary safety outcome was a composite score of all-cause mortality, symptomatic ICH, and major extracranial hemorrhage. One patient taking rivaroxaban experienced a spontaneous symptomatic subdural hemorrhage requiring surgical evacuation after being on rivaroxaban for 3.5 months. And on the other hand, the standard of care group had 0 participants for that primary outcome. Now, going over the secondary outcomes at day 180, one patient in the rivaroxaban group experienced asymptomatic and worsening of the hemorrhagic component of the baseline parenchymal lesion after 24 hours following randomization. So this accounts for 2 patients with any ICH incidents by day 180 for rivaroxaban group and 0 for the standard of care group. 2 patients in the rivaroxaban arm and none in the standard of care arm experienced clinically relevant but non-major bleeding events before day 180. One was related to heavy menstrual bleeding, and the other one was related to postoperative infection after hysterectomy. And one in each group was found to have asymptomatic new CVT event by day 180, and by day 165, which were the cumulative outcomes, one participant in the standard of care group experienced symptomatic traumatic subdural hemorrhage and simultaneously suffered a clinically relevant non-major bleeding with scalp bleeding. And this same participant died, unfortunately, during a separate hospital admission due to an unrelated reason. Recanalization was also evaluated at day 180 using the D'Souza grading score, which ranged from 0 to 3. Higher the grade, the better, meaning that the patients with grade 3 had a complete canalization. 100% of participants in both groups had at least partial recanalization, grade 1A or better, by day 180. And a high percent of participants, so 83% in rivaroxaban and 92% in the standard of care group, had recanalization grade 2A or better, meaning that they had partial recanalization of all thrombosed vessels without any persistent occlusion by day 180. And a lower percentage of patients in both groups achieved complete recanalization by day 180. In respect to patient-centered prognosis, they found that most patients were functionally independent even at baseline, evidenced by the modified Rankin score. More than 75% of patients had MRS score ranging from 0, meaning no disability, to 3, and a few scored 4 or higher, indicating poor neurologic outcome. But despite the baseline MRS score, there still was a substantial improvement over time, even at day 180, with MRS score of 3 being considered the worst outcome in both rivaroxaban and standard of care group. The SECRET trial also assessed other patient functional outcomes like the Euro-Quality of Life, Population Health Questionnaire, Headache Impact Tests, and many more. And on average, participants experienced improvements in all patient-reported outcomes over time between baseline at day 180 and even at day 165, with no notable difference between the two groups. So to conclude, they were able to demonstrate the feasibility by reaching the recruitment target of greater than 50 participants. There were numerically more bleeding events with rivaroxaban at 180 days compared to the control arm, but the rates did not exceed what has been reported in previous CVAs evaluating the use of DOACs. And lastly, participants had comparable symptoms between the groups, affecting their well-being at enrollment, but improved over time. So going into critiques for strengths, they were the first randomized controlled trial to assess the safety of an early initiation of DOAC therapy within 14 days of CVT diagnosis. And they were also the first ones to look at the use of rivaroxaban in the setting of CVT. Second strength is the generalizability of the study, being that it was analyzed as modified intention to treat. And lastly, this study had a longer follow-up up to 365 days, which was lacking in previous studies. And I also want to point out that this trial explored patient-centered outcomes such as functional independence, quality of life, which are important elements in considering the prognosis of CVT. Now, going over limitation, first, the study was underpowered to test for superiority or non-inferiority. And the open label design of the study may have also led to some biases toward reporting bleeding events in the experimental arm. Out of those who were eligible, nearly half of them declined to be enrolled into the study, kind of alluding to the fact that a lot of these participants were not comfortable being on rivaroxaban versus this previous standard of care being warfarin. Also, those with more severe presentations were underrepresented and not reported. So patient risk of bleeding, head trauma, malignancy were not included in this study. So the role of DOACs in these patient populations still remains uncertain. And lastly, I also want to point out the limitations in regards to the rivaroxaban dosing. Unlike the treatment of acute DVTs and PEs, where the initial dosing of rivaroxaban is 15 milligrams twice a day for 3 weeks, followed by 20 milligrams daily. Participants in the SECRET trial received the initial dosing of 20 milligrams daily. The lower dosing regimen was selected to reduce the risk of early worsening intracranial hemorrhage, but I do think that the full dose anticoagulation regimen should have been reviewed in patients with CVT population. Overall, the SECRET trial was able to demonstrate the safety of rivaroxaban compared to the standard of care group, which included low molecular weight heparin and warfarin. The simplicity of rivaroxaban dosing and monitoring listed here improves medication compliance, and which ultimately can lead to better clinical and safety outcomes in patients with CVT. Overall takeaway points are that rivaroxaban provides similar efficacy and safety outcomes as warfarin in selected patient populations, so those who are stable with CVT as early as 14 days of diagnosis. And with the updated AHA guideline, I am hopeful that more institutions will be comfortable incorporating the use of DOACs into their practice, even though there still is no fully powered randomized comparative trials. There, however, is still that unanswered question with the total duration of anticoagulation in CVTs. Fortunately, there is an ongoing trial looking at the benefit of extending oral anticoagulants up to 12 months to kind of help us guide us in managing the anticoagulations in patients with CVTs. So that concludes today's journal club presentation. I am open for any questions. Thank you.
Thank you, Dr. Shim. I see one question already in the chat. Does your institution routinely use apixaban or rivaroxaban for this indication, and does this trial change your practice?
That is a great question. So unfortunately, during my month on neuro ICU rotation, I did not have anyone with CVT, but I was able to talk to one of the mid-level nurse practitioner last week about just like going over this trial with her. And she did tell me that they recently discharged a patient with CVT on apixaban, which I thought was interesting, but I really think it just depends on patient's insurance and coverage and how well the patient can be adherent to their medication regimen.
Yeah, great. I have one question. I think just like you said, as far as the limitations of this study, they really included that subgroup of patient population that we truly don't see in the ICU setting, right? Everyone kind of presented with NI scale of 0, literally no symptoms. So I think this is really not a good representation of maybe the CVST that we typically get in the ICU setting, where patients are very sick, they are seizing, or they have ICP crisis and things like that. Do you think if this was something that we wanted to start, let's say in more sick patients, that we really want to make sure that we're getting truly effective concentrations, is there a role for checking anti-10A level in the sicker patient population, given that, you know, with this disease, part of the problem is that you want them not to bleed by not overdosing them, but you also don't want to undertreat them, because if you undertreat them with the, you know, venous congestion, you can cause more bleeding. So it's really, really hard to, I think, put these patients on a medication that you cannot actively monitor, especially in the ICU setting. What do you think about that? Do you think there's a role for these patients being on DOACs with anti-10A monitoring in the ICU, or do you think we should just commit to short-acting agents such as heparin, or, you know, a Lovenox, which is the newest recommendation from the guidelines?
Yeah, that is a great question. I don't really think there are benefits in utilizing anti-10A monitoring for patients on DOAC, just because I don't really see, I feel like every time we get an anti-10A level in patients who are presenting to the ICU on a DOAC, it's severely high, like super therapeutic, and everyone freaks out and they end up like just holding the DOAC. And I don't think there is that benefit of starting a DOAC in the ICU. And like you said, I think the better alternative would be starting them on a heparin drip or even Lovenox to begin with, and kind of making sure that they are stabilized and ready to be downgraded and consider trying a rivaroxaban or another DOAC agents. But I do not see the feasibility or see the benefit of checking their anti-10As for patients on rivaroxaban.
Yeah, excellent. I think most centers, including us, we don't really even have the calibrated anti-10A levels. So what we see is really just qualitative, like yes and no, if the drug is present or not. But I agree with you. I think part of the challenge in our patient population is that so usually they're so sick that it's hard to commit them to this. But I think for discharge planning, as you just mentioned, if their insurance can cover and people are stable, this may be a very good plan. I think there's one question that I missed for our prior presenter, Dr. Harbaugh. I think there was a question about, did the study with Argatroban mention how they managed bleeding in that low percentage of patients that bled on Argatroban?
I did not specifically see anything in the study that mentioned how they managed bleeding patients in that study. I might have to go back and take a closer look, but I don't recall anything in the supplemental or primary paper that stated anything about that.
All right, great. Any other questions for our excellent presenters today? I don't see anything. Thank you, guys. Very good job. Excellent work. And we'll see everyone for our next journal club in March. Have a good Tuesday, everyone. Bye.